Okay. Hello, thank you very much for this invitation to the summit meeting to present on our project, the global mental health impact of the COVID-19 pandemic. And I'm presenting today with some members of the team and on behalf of the other co-PIs. Next slide, please. So this 3-site project, led by 3 PIs, myself representing the University of Oxford, Andre Brunoni, the University of Sao Paulo, and Jordan Smoller from Harvard Medical School in the USA. And we've conducted this project for over 2 years across these 3 sites and across these 3 countries. And but not only have we been leading this project over the 3 sites, but we've been importantly leading this project with a very important team of analysts, data scientists, and project support team. And today it's really about the team that has been working very closely with us to make this project such a success. Next slide, please. So the IHCC COVID-19 Mental Health and Behavioural Impact Scientific Working Group was awarded our pilot grant to leverage the resources of the IHCC consortium to address the pressing questions related to COVID-19 and mental health. So we've managed to harness the collaboration of over 23 global cohorts across almost 2.5 million individuals using IHCC collaborative cohorts, as well as those from Dementia's Platform UK, for whom I am a senior data manager and a senior scientist. Didn't introduce myself, but there I have. And so we have worked on 3 major aims. Next slide. So catalogue and categorise cohorts with a mental health assessments both pre-pandemic and during COVID-19 to identify a set of subdomains and assessments for harmonisation and cross-cohort investigations, and also to address core scientific questions related to mental health and COVID-19. Next slide, please. So the 3-site project has met remotely since 2020 to discuss the project strategy, the analytical plans, and also preliminary findings. The PIs from each group has worked closely with the whole team to steer scientific output and to lead project direction. So the team of researchers, some of whom you will meet today, have produced 4 publications with a further 2 in progress and are now working on a group effort NIH grant to extend the project for a further 3 years. Next slide, please. I would like to importantly introduce members of the research and support team to present on their contribution and experience working on our project. Heather Lee from Mass Gen Hospital, Harvard Medical School, Dia Kabir, also from Mass Gen Hospital, Daniel Fattori from the Faculty of Medicine, University of Sao Paulo, and Josh Baumeister representing Department of Psychiatry, University of Oxford, and Dementia's Platform UK. So I'd like to move on to our first speaker, Heather Lee.
Thank you, Sarah, for the wonderful introduction. As Sarah mentioned, I'm a postdoc working with Dr. Jordan Smoller at the Mass General Hospital in the United States. Here, I'd like to mention that I had such a tremendous privilege of working, of getting mentorship from 3 amazing mental health researchers through the IHCC COVID Mental Health Working Group. In this collaboration, I was able to get a super helpful feedback on analysis, manuscript, but also such wonderful training opportunities in grant writing, which is such an important skill for early career researcher like I am. So today, I'd like to introduce one of the analysis that we conducted through this collaboration using the All of Us research program. In this study, we examined the association of everyday discrimination of depressive symptoms and suicidal ideation during the COVID-19 pandemic in the All of Us research program. Next slide, please. So for those who are not very familiar with the All of Us research program, it is a longitudinal cohort of 1 million or more participants reflecting the broad diversity of the United States. They made a tremendous effort of recruiting individuals from communities that have been historically underrepresented in biomedical research. And that includes racial and ethnic minorities and sexual gender minorities and people of low income or limited education. And the specific type of data that we used for our analysis was the COVID survey that they collected during from the early phase of the pandemic, and it's called the COPE survey. And the bar plot at the bottom demonstrates one of the considerations that we had while working with the COPE survey data. So so there are legend at the bottom, but I understand that it's kind of, the letters are a little tiny to read. So one thing that I would like you to focus on is the section in green. So the section in green represents individuals self-identifying as non-Hispanic white. And as you can compare from the top bar and the bottom bar, you could see that the size of the green section has increased tremendously among the COPE survey respondents, and this indicates that the COPE survey respondents may have had a much reduced diversity in terms of race and ethnicity relative to the overall all of us cohort. Next slide, please. We then went ahead and compared other aspects of participant characteristics of the COPE survey respondents against the overall all of us cohort. And the rater plot on the left side indicates that we are observing what is commonly known as the healthy volunteer bias. And some of the aspects that we examine include insurance status, college education, employment status, homeownership status, and marital status, and annual household income. And as you can see, we could see that the COPE survey respondents had much higher socioeconomic status than the overall all of us cohort. And the second methodological consideration that we had was the repeated measurement of the COPE survey. Prior to the IHCC COVID mental health working group collaboration, I didn't actually have so much experience working with repeated measures data. However, my wonderful collaborators at Oxford and University of Sao Paulo have been very helpful in terms of picking the right models to address these unique methodological aspects of the COPE survey that I was working with. Upon their recommendation, I was able to pick the mixed effects models that would subject-specific random effects and fixed effects for survey timing. And I also incorporated inverse probability weighting, which is a causal inference method that accounts for non-random probabilities of completing the voluntary survey. Next slide, please. In this study, the primary exposure was everyday discrimination measured using widely accepted measure called everyday discrimination scale, and the secondary exposure was the main reason for discrimination, and this was actually included as the last item of the everyday discrimination scale. And the primary outcome that we used was depressive symptoms and suicidal ideation, and those were ascertained using patient health questionnaire, also known as PHQ-9. Next slide, please. In this analysis, we found a strong association between moderate to severe depressive symptoms and everyday discriminations. And the top figure shows the association between depressive symptoms, and the bottom figure shows the association with the suicidal ideation. They were both strongly, these were very strong associations. So to help you understand this figure, individuals experiencing discrimination more than once a week were more than 17 times as likely to report moderate to severe depressive symptoms. And those who are experiencing discrimination more than once a week were nearly 11 times as likely to report suicidal ideation. And this is like a really striking finding for us. And the panel on the right indicates further variation of this association by survey timing and self-reported race and ethnicity. And to quickly summarize, we identified that the association between everyday discrimination and depressive symptoms was particularly evident when the main reason for discrimination was due to race or ancestry or national origins among Hispanic or Latino participants, especially early in the pandemic, as well as among those self-identifying as non-Hispanic Asian. Next slide, please. To quickly summarize, we found a very strong association between everyday discrimination and depressive symptoms and suicidal ideation in a large-scale longitudinal investigation of a diverse sample based in the United States. And we found further variation of this association by survey timing and race and ethnicity. And this work has been published in JAMA Psychiatry, and please feel free to use this link if this link works, or like Google our study to read more about it. Thank you very much.
Hello, everyone. So my name is Dia Kabir, and I am a CRC for Dr. Jordan Smoller in the team. So thank you, Sarah, for inviting me to speak here very briefly on the admin end of things. And being a CRC, what I want to highlight is that myself and others on the admin end, we really help out with the infrastructure and organization of the project. So the day-to-day of coordinating meetings, tracking deadlines, tracking progress. And really the valuable part of this role is that it is the team's investment in keeping communication channels open between the research team and between the program managers and the program. And when it comes to grants, IRB work, and other deadlines, we really help to coordinate and to make sure that things are moving smoothly and seeing that the team is assisted with what they may require in terms of paperwork, grants. As Heather mentioned, we are working on a grant, and that has been a fantastic learning experience for me. And as a note as well, Dr. Smoller is part of the Center for Precision Psychiatry department at MGH. So I have noted down some key goals of the department. As you can see, treatment optimization, neuroscience and novel therapeutics, suicide prevention, and etc. So it is really valuable to remember that these goals are at the forefront of the team's work, and that also really informs me in trying my best to help the team out. Next slide, please. All right, so the main takeaway from working on a centralized project structure is that it does really help keep the communication open. Having those channels open really fast tracks communication and helps plan workload, goals, data policies, etc. And I do have some admin involvement in Dr. Smoller's work in the PsychMerge and eMerge networks as well. So these are all multi-site networks that work with large-scale EHR and biobank data. And really, it has been fantastic to see how this large-scale structure really accelerates the momentum and helps the collaboration come together so seamlessly. Next slide, please. So again, really briefly, to just close on a few positive notes, it has been so fantastic to be part of the project at such an early stage in my career, to help with the grant writing, to help keeping the meetings going, and etc. And it has been really great to see the science come to life on a level that I previously have not been exposed to, and such a learning experience to see how I can also develop myself into learning what creates a good research environment. And optimistically, the team's focus on advancing patient care and patient experience has been such a great lesson and also a role model for me to continue on in the future years. All right, so that's everything I have to say. Thank you for listening.
Thank you, Gia. Hello, everyone. My name is Daniel Fattori. I'm a researcher at the University of São Paulo Medical School, and I'm also a part of the Global Mental Health Impacts of the COVID pandemic scientific group. Next slide, please. So my main role in our group was to focus on the analysis of data that we conducted here in Brazil, more specifically the ELSA Brazil COVID-19 mental health cohort study. This was a study led by Professor Andrea Brunoni, who is also a part of our scientific working group. So just to put things in context, the ELSA Brazil is a cohort that started around in 2010. It is a cohort originally designed to study the determinants of morbidity and mortality, especially in heart disease, but it also has a very interesting and robust mental health component. So during the pandemic, Professor Andrea Brunoni led a team that conducted these online assessments of mental health. And since the cohort was a pre-existing one, we had also data from before the pandemic. So this was a very interesting opportunity to compare data before the pandemic with data during the pandemic. So in our first paper, I'm not going to show our first paper here, but just to mention, in our first paper, we showed that the COVID pandemic didn't affect the population. It had, in fact, a very small effect on the population of our cohort study. So considering these results, these initial results that we published first, we decided to use a cluster-based approach to see if we could identify groups of individuals who were more affected by the pandemic. Since when we analyzed the sample as a whole, we didn't find much difference. So next slide, please. So for this purpose, we used a statistical technique that is called group-based trajectory modeling. And with this strategy, we didn't have any a priori hypothesis. It is a very data-driven approach where we try to model the best way that we can the data. So after a lot of testing and a lot of tweaking, we found these 6 groups that you can see in your screen. In the x-axis, you can see the time from all the way to before the pandemic to the latest time point during the pandemic. And in the y-axis, you can see common mental disorder symptoms. This is basically the depression, anxiety and stress scale, the DAS-21. And also, as you can see, most people in our sample wasn't affected by the pandemic. So most groups had low to moderate symptoms, but one group in light red, as you can see, had high symptoms with a trajectory that was chronic all the way up to the last point when we saw a pattern of a reduction in symptoms in April to June 2021. So next slide, please. So after we found the trajectories, our main idea was to look to these trajectories and try to see if we can find risk and protective factors profiles of each trajectory. So for the purpose of this presentation, I will only show the risk and protective factors profile of trajectory number 6. That is the most important one, since it was the group with a chronic trajectory. So in this graphic that you can see here, we have all the factors that we tested, and I highlighted in red all the factors that were significant at a p-level of 0.005. And so being older than 60 years, also being non-sedentary was a protective factor, but also a family income was also a protective factor. If you have more money, you have more protection from the effects of the pandemic. But being female, previous mental disorders and adversities in childhood and during your life was a risk factor for mental health problems during the COVID-19 pandemic. So for more details on our methods and all the other risk and protective factors profiles, you can see our paper in the link that I show below. So next slide, please. So for me, it was a great pleasure to work with all the PIs, Sarah, Jordan, and Andre, and all the analysts. We had weekly meetings discussing the data, discussing method, discussing statistical techniques. So we played a lot with our data, explored a lot with our data, but we were very, very focused on having meaningful results, because as an analyst, sometimes we have like this temptation to test like everything, try to find something interesting, but all the time we discussed that we need to keep a focus on very meaningful variables, factors, to have meaningful results that can be used in the future to plan interventions and to plan public health interventions and so on and so on. So it was a great privilege working with this group, and I hope to continue this in the next years. We have a lot of data, a lot of interesting ideas that we wanted to pursue in the next month and next years. So yeah, so thank you for being a part of this group.
Hello, everyone. Thank you for having me to speak here. My name is Josh Baumeister. I'm a data scientist at Dementias Platform UK, based at the University of Oxford. This is a little bit about the nitty-gritty of some of the steps that we had to go through for some of the collaborative parts of this project. Next slide, please. So obviously we're dealing with three PIs stationed in Brazil, the USA, and the UK. So these PIs come with a lot of contacts and cohorts that they work with from all over the world, of great interest to our projects. But the challenge there is, how do we actually work with many different cohorts from all different walks of life? So as you can see, there's 23 different cohorts here, all from many different sort of areas of different populations and of different sort of starting backgrounds. Next slide, please. So one of the main things that we do here at DPUK is we standardize and harmonize our cohorts according to our CSERV curation program. So we are quite well suited to standardizing and harmonizing cohorts for cross-cohort analyses. So this is a picture here of our top-level ontology of 18 different categories, which we then utilize to standardize and clean up the 23 different cohorts. Next slide, please. So once we had a deeper look at the cohorts, we then generated a table of priority sort of variables of top-level administration, socio-demographic, etc., and then further split them down into subcategories in a big table, so we could see and really pinpoint the cohorts of greater interest out of those 23. Next slide, please. Working with many different cohorts obviously poses a more detailed problem at variable level when you've got many different coding conventions for variables. So these three here on the left are from three different cohorts, and they all mean the same thing: ever had pain in chest. But obviously it's quite tricky working with variables you don't actually know what the names are. So this is future work that we're going to do for this task, is we're going to actually apply a common naming structure, which we do at DPUK. Next slide, please. So here is a bit more information about our common naming structure for the variable levels. As you can see, as an example from Generation Scotland, and this is how we code our variables. So the pain chest ever is the common measurement name. We then have a prefix for the cohort ID, and then we have a underscore wave and array for attention. And this is just a further breakdown of our top level ontology into sub, theme, and further down to objects or variable level. Next slide, please. So another thing we also plan to do is DPUK, we have worked with harmonization techniques. So for us to harmonize a core set of variables for these projects, I think will be very valuable. And we are currently working on some rules to harmonize key variables, and to then also be able to send out those rules to cohorts who have a stricter sort of sharing policy on their data, so that we can have a more federated approach to analyses. Next slide, please. So this is just a bit of a fun slide to say that we've overcome a lot of things, working on 3 different sites, 3 different PIs. Some of us graduated meantime, and others have had babies, myself. So it's really been a great learning opportunity for us, and collaboration sort of thing that we did together. It's really been great fun, and really been a superb opportunity for myself and to work with everyone here. Next slide, please. And that's just a picture of all 3 campuses on their good days. Thank you very much.